Hello, my name is Dr. Laura Lewandowski, and I'm a Pediatric Rheumatology Fellow at Duke University Medical Center. I'm going to talk to you today about granulomatosis with polyangiitis, or GPA, formerly known as Wegener's granulomatosis. The learning objectives for this talk. In the next 10 minutes, we're going to cover the classification criteria for GPA, learn to identify clinical signs and symptoms, which would raise your level of suspicion for GPA, review other diseases considered in the differential diagnosis for GPA, and discuss the labs and studies which help to rule in or rule out this diagnosis. As I covered in the learning objectives, we'll start with the clinical presentation and diagnosis. We will then move on to the treatment of GPA and summarize all that we have covered. Granulomatosis with polyangiitis. This disease was formerly known as Wegener's. The name was recently changed from the eponym to a more descriptive title. It is a systemic vasculitis, which means that it can affect multiple organ systems. We will talk about the organs most involved as we move through the review. GPA is a vasculitis, which means inflammation of the blood vessel walls, and small and medium-sized arteries are targeted in this process. GPA is one of the ANCA-associated vasculitides, meaning anti-neutrophil cytoplasmic antibodies are detected in this disease. Often, the upper and lower respiratory tract are involved, as well as the kidneys, making GPA one of the known pulmonary renal syndromes. Although we will see as we go further that other organ systems can be involved as well. The clinical presentation of GPA classically occurs in ages 30 to 50, although it can range from children as young as 5 years to the elderly. It is a rare disease, and the incidence of GPA is 15.6 cases per million people in the United States. The prevalence of this disease is 123 cases per million. Since it is a systemic autoimmune disease, fever, malaise, weight loss, and fatigue are often seen. In addition to the systemic symptoms, the upper respiratory tract is targeted quite frequently. Upper respiratory involvement can present as recurrent epistaxis or nosebleeds, nasal ulceration, which can be extreme to the point of nasal perforation, or more simply, bouts of recurrent nasal inflammation, which can lead to recurrent episodes of sinusitis. Additionally, GPA can involve the inner ear with otitis media, which can lead to hearing loss. It can cause recurrent episodes of inflammation of the vocal cords and arytenoid cartilage, which cause changes in voice. In addition, some patients develop subglottic stenosis. The lower respiratory tract is often involved. On board exams, this tends to show up as a new onset pulmonary hemorrhage. Clinically, pulmonary hemorrhage presents as acute shortness of breath with hypoxia and hypercapnia. GPA also presents with parenchymal nodules, which can be seen either on plain radiographs or on CT scans of the lungs. These nodules can be solid or cavitary, and tuberculosis is in their differential diagnosis. Regarding symptoms, individuals may experience more chronic symptoms such as chronic cough, with or without hemoptysis or recurrent pneumonias. GPA has characteristic renal involvement, which, similar to the pulmonary involvement, may be either acute and catastrophic or more chronic and insidious. Most often, this presents as glomerulonephritis, with hypertension, hematuria, and edema. If the onset is more chronic, it may be more subtle, with proteinuria, anemia, or fatigue. Biopsy of the kidney reveals what is called pauci-immune glomerulonephritis. This means that in contrast to the renal lesions in systemic lupus erythematosus, using immunofluorescent staining, antibodies and complement are not deposited in the glomeruli. Since GPA is a systemic autoimmune disease, fever, malaise, and weight loss are often seen. The eyes are also frequently involved. Ocular involvement presents as acute scleritis or pain and injection of the sclera, which is clinically apparent. It can also present as retinal vasculitis, which may be more clinically silent until vision becomes compromised. The vessels of the heart can be affected, and this is most often a global process. If the entire surface of the heart is affected, there is a pericarditis, often with effusion. There can be a more global involvement which presents as myocarditis, often with a decrease in function of the heart. This can present as exercise intolerance or florid heart failure. Skin is also commonly involved. The rash of GPA is a vasculitic rash, meaning it does not blanch. It can be hemorrhagic and purpuric, or less often vesicular. The differential diagnosis for GPA involves many other autoimmune diseases. The most common disease to think about is Goodpasture's, which is a pulmonary renal syndrome that presents nearly identical to GPA. It has a very classic appearance on renal biopsy and does not involve the upper respiratory tract. Microscopic polyangiitis and polyarteritis nodosa are rare autoimmune diseases which can present with similar symptoms. Microscopic polyangiitis does not have granulomas found on tissue biopsies. Churg-Strauss is an ANCA-positive small vessel vasculitis associated with asthma and eosinophilia. Systemic lupus erythematosus is a common autoimmune disease which can affect any organ system and often presents with glomerulonephritis. Syphilis is infectious, but can present later as a vasculitis if untreated. It also can be associated with a saddle nose deformity. When you do initial laboratory investigation, you will often find signs of systemic inflammation. These include elevated WBC count, a high erythrocyte sedimentation rate, and a high C-reactive protein. The C-reactive protein is a more real-time reflection of inflammation, which will increase with acute flares and decrease more quickly than the ESR. More characteristic of GPA, however, is detecting a positive Inga. The urinalysis will show signs of glomerular disease, including proteinuria, hematuria, and often red blood cell casts. ANCA stands for anti-neutrophil cytoplasmic antibodies. These are antibodies against cytoplasmic granules in the white blood cells, and the patterns of staining classify them into different categories. Cytoplasmic C-ANCA or perinuclear P-ANCA are the two categories. The antigens detected in the ANCA screen have been identified as proteinase 3 or PR3 and myeloperoxidase or MPO. GPA is associated with a positive C-ANCA, and anti-PR3 antibodies are detected in 95% of the cases of GPA. The detection of ANCA can change during the course of GPA. So early on, if GPA is limited to the respiratory tract, only 50% are ANCA positive. Later, that may increase to as much as 90% if there is systemic involvement. Histopathology. Granulomas of the upper and lower respiratory tract and the kidneys are the most common finding in GPA. Granulomas are organized collections of monocytic cells which are surrounded by T cells, B cells, or eosinophils. Granuloma formation is a normal host response to a poorly degradable intracellular pathogen. Imaging in GPA. This is an imaging of the parenchymal nodules which are seen on pulmonary CT that we mentioned earlier. The pulmonary hemorrhage of GPA appears as bilateral diffuse fluffy infiltrates on a chest X-ray. The treatment of GPA. GPA is an autoinflammatory autoimmune disease of the blood vessels. Therefore, the treatment is aimed at quieting the immune system. IV glucocorticosteroids are used acutely as they are potent and work quickly. There are steroid-sparing agents which are used as well. Cyclophosphamide is a nitrogen mustard which targets cell division and therefore halts the division of the white blood cells, leading to decreased inflammation. Cyclophosphamide has been proven effective for the treatment of GPA in randomized control trials and is the initial treatment used to induce remission. Following remission, patients are treated with maintenance immunosuppressive medication orally, often for many years. If the patient is having an acute pulmonary hemorrhage, plasmapheresis is indicated. Treating GPA is imperative because if left untreated, 90% of patients will die in 2 years. Even with treatment, the disease often has a relapsing course, with multiple flares which require increased immunosuppressive therapy. In summary, GPA is a pulmonary renal syndrome. It is a disease of the small and medium vessels of the body. It is an ANCA-associated vasculitis, and the characteristic pathology are necrotizing granulomas seen microscopically. It is a disease of the upper and lower respiratory tract and the kidneys, Left untreated, it has a high mortality, and the natural history is that this is a relapsing disease. These are the key references used in compiling this talk. I would like to thank Dr. Lisa Criscione Schreiber for thoughtful review and Duke University Medical Center for assistance with this talk.